Renal cell carcinoma accounts for 3 to 5% of all cancers and is the most common type of kidney cancer. Approximately 25% to 30% of RCC patients are diagnosed with metastatic RCC, with an estimated 5-year survival rate of 5% to 50%. Recently, the clinical practice guidelines from the European Association of Immunology and the National Comprehensive Cancer Network advocate for the integration of ICI in tandem with TKI as the first-line treatment for patients with mRCC. The current clinical indicators for predicting the response to TKI plus ICI in first-line treatment for patients with mRCC are insufficient. The study aimed to investigate the feasibility of pretreatment PSMA PET-CT for predicting treatment response in patients with mRCC undergoing first-line therapy TKI in combination with RCC. The inclusion criteria were histological confirmed mRCC. Patients who received TKI plus ACI as first-line systematic therapy. PSMA PET-CT performed parallel treatment. At least one lesions were measurable in accordance with RECIST 1.1. Patients who met all the above criteria were included in this study. The inclusion criteria were patients for who more than 1 month and had passed between the last PSMA PET-CT and the initial treatment, last to follow-up prior to a response assessment, and incomplete clinical pathology date. A total of 108 patients with mRCC who underwent pre-treatment PSMA PET-CT and treated with first-line TKI plus ACI were included in the final analysis. Univariate register regression analysis when used to identify factors associated with treatment response, defined as CR or PR, and variables with p-value less than 0.1 were included in this analysis. Multivariate register regression analysis was then performed to determine independent predictors and develop a predictive model based on independent predictors of response to the combination of ACI and TKI. RC analysis was performed to evaluate the discrimination performance of the independent predictors and the combined model, and the area under the RC cover values when compared using Dillon test. Sensitivity, specificity, and positive and negative predictive values when obtained using the optimal cutoff value. The ROC cover was used to identify the optimal cutoff value according to the maximal Yoden index. Kaplan-Meier survival analysis was conducted to estimate PFS and the difference between survival covers when compared using the long-rank test. The most common histological subtype was clear cell RCC. The median follow-up time was 10.8 months. According to the RECIST 1.1, 12 cases showed CR, 24 showed PR, 45 showed SD, and 27 showed PD. Univariable register regression analysis revealed that ECOG score, mRCC risk score, IMDC classification, PSMA SUV max, PSMA SUV pink, PSMA AUC-CSH, and PD-L1 expression level when associated with response to TKI and ACI in patients with mRCC. Multivariable register analysis identity PSMA AUC-CSH, PSMA SUV max, and PD-L1 expression level as independent predictor of treatment response. ROC analysis revealed that the AOC for AOC-CSH was 0.812, while the AOC for SUV max was 0.757. The AOC for PD-L1 expression level was 0.637. Kaplan-Meier analysis demonstrated that the patients with lower PSMA had gradually extended significantly longer PFS than those with higher PSMA heterogeneity. ROC analysis revealed that a combined predictive model incorporating LC-CSH, SUV max, and PD-L1 expression level achieved an AOC of 0.88. Dillon test analysis further demonstrated that the AOC of the combined model was significantly higher than that of LC-CSH alone. In conclusion, in its retrospective study, we found that the AOC-CSH and SUV max derived from pretreatment PSMA PET-CT scans were independent predictors of response to TKI plus ICI in mRCC. Higher PSMA heterogeneity and lower PSMA SUV max were associated with unfavorable outcomes in patients receiving treatment with TKI and ICI. When combined with the PD-L1 status, the use of AOC-CSH and SUV max may enhance patient stratification and facilitate clinical decision-making before treatment initiation.